where we were to where we are today. Because I think stories are real important. And one of the things I've learned in my career is that stories are probably a bit more important than anything else. So right now, we're in the middle of probably the third big focus on states in terms of health and health reform that we've had in about 50 years. And the first one was 50 years ago. This is Lyndon Johnson and signing Medicare legislation. And the beginnings of Medicare and Medicaid clearly, for the first time in our country, put the focus squarely on states and how it is states were going to suddenly implement these programs. I mean, Medicare, there was a thought that we would cripple states with Medicare. Medicaid, I think, as you know, is a state-federal partnership, and it really started to put the focus on states, and we got through that. And then about 30 years later, we had this. This isn't Hillary, but actually it was Hillary. This is 1993, and this is the Clinton Health Plan. And again, we had an incredible focus on states and how states were going to reform. Our state, Oregon, was one of those states that dramatically tried to influence its whole healthcare system. We created the Oregon Health Plan. We created what at that point was a dirty word, how we would begin to ethically and rationally look at how we distribute health services in our state. And this was from the Hartford Courant. 5 states, this is the front page of the Hartford Courant from exactly September 20th, 1993. 5 states came to Hartford to speak to the Hartford legislature about why it is they, as 5 states, were making dramatic changes in their healthcare systems. This was Florida, Oregon, Minnesota, Washington, and Vermont. And their message to the Connecticut legislature was, in essence, just do it. You have the power to change your whole state's healthcare system. And I think we know now, 20 years later, that really didn't happen. And now we're in the midst of the third big wave of focus on states, and that's with federal reform. This one a little bit different from the others, because for the first time, rather than sort of, in many ways, putting the focus on states, really innovating in a certain way, what federal reform has done, unfortunately, has caused an incredible division between states in our nation. And it's all focused on what's been a really interesting Supreme Court decision, not about insurance exchanges or mandates, but around whether or not states should or shouldn't expand their Medicaid populations. And that's created an incredibly political, divisive, and geographically divisive picture. Oh my goodness. I don't even know how to.
Yeah, click.
Maybe I do.
No, click on the, back on the, yeah, there.
There we go. I like this division a little better of our states, but we've created a really divided nation. So what I want to talk to you about today isn't about how we divide, but actually how you can, in a state like ours, which is about as evenly divided politically as you can be. When we instituted our health reforms, we had a Oregon House of Representatives that was 30 people Democratic and 30 people Republican, and a Senate that was 16-14. So divided right down the middle, and how we were able to enact statewide reform that was accepted by both parties in the midst of what was a pretty dramatically divided divided country. So before I get into that, let me just mention there's probably really only 3 things that states do, 3 roles that states have in healthcare. One, they're regulators. They license physicians, they license insurers, they license our public health system. And indeed, there's been some great examples of how states have use those powers to leverage change. Rhode Island had a guy named Chris Kohler, a really visionary insurance commissioner, that used his power as insurance commissioner to mandate that a certain percentage of health insurance premiums be devoted to primary care. Hawaii just used its powers to be the first state in the nation to make it illegal to buy cigarettes if you're under 21. States have done some pretty good things as regulators, but they've tended to be sort of one-offs. Second role states have is as purchasers. States are tremendous healthcare purchasers, and states purchase anywhere from about 20 to 30% of the healthcare in their state. They do that through purchasing. Medicaid is the biggest place. Medicaid, a federal-state partnership. States purchase a lot of healthcare. They purchase healthcare for public employees, for teachers, for other government workers, through their departments of corrections. And we'll talk about that because we use that purchasing power to strategically leverage a lot of our change. And then the last place that states are in the healthcare business, and it's probably the smallest piece, is as providers of care. States provide some healthcare services. They provide public health services. They do some mental health services. They provide some corrections health services. But the biggest piece that states do is purchase healthcare. And every state is dealing with healthcare in exactly the same way, and we're all dealing with the same issues. And rather than showing you PowerPoint slide after PowerPoint slide, I have distilled the issues in healthcare down to 2 slides for you. And here they are. This is the first problem in healthcare. Anyone know what that is?
Cost.
Could be. What else? Growth in population. This is absolutely everything in healthcare. All this is some numbers on one. It's fascinating that everybody always goes to cost. It's some numbers on one side and some dates on the other, but we rarely see anything that goes down in healthcare. This is cost, this is copay, this is premium, this is the number of political pundits talking about healthcare any day. This is the number of codes in ICD-10 as compared to ICD-9. There is absolutely nothing that goes down in healthcare, and that's what we're dealing with, is how do we moderate healthcare? Then here's the other one. And what's this? This is everything else in healthcare. We're a giant scattergram. This is outcomes. This is 50 different hospitals, cardiothoracic surgery outcomes compared by cost and quality. Actually, that's exactly what that is. But that could be physician distribution. That could be 50 different practices around Durham, North Carolina, and their ability to lower cholesterol. It could be anything. It unfortunately could be one of the other big problems in our healthcare system, which is disparities. This could be death rates from diabetes based on race, ethnicity, and geography. Because we know we have huge problems with health disparities in our country. You know, in our state, we have, if you are African American, you're twice as likely to die from complications of diabetes than if you're white. And I'm sure that many of those same disparities exist across the rest of our country. You know, we know that you're 2.1 more times likely to have asthma if you are African American, 9 times as likely to have HIV. So we know we've got huge disparities, and this is really the environment that every state is in. Rising costs, everything going up, rising copays, rising premiums, rising codes, increasing complexity, healthcare costs growing faster than anything else, any other economic indicator, creating what's really unsustainable. As healthcare costs increase 5, 6, 7, 8, 10%, depending on the year we're in, and every other economic indicator increasing 2 and 3%. It robs money from our other good human endeavors, from transportation, housing, the arts, education, and healthcare keeps sucking it up. And the outcomes aren't what we want. We don't want to see these disparities. We'd like to see equity. We don't want to see people not have health care. We'd like them to get that. I think all of us in every state have a belief that we can do better, that we can actually have a healthcare system that functions effectively, that helps get us the outcomes that we need. And indeed, this is cost. We know that healthcare costs are predicted to double in the next decade. This looks at healthcare premium. In blue, it looks at workers' contribution to premium. In orange, you can see both those have gone up over 180% since 1999, and compared that to general inflation and workers' wages. This is wasted or ineffective. And if you don't believe in what Don's done or what others have done, that's great. But I don't think there's anyone who could stand up and say, we are humming on all cylinders and we've created the most efficient and effective system. We've got a fair amount of waste and inefficiency. And the question is, how do we get rid of it? So states and pretty much everyone else have done the same 3 things since Lyndon Johnson sat there and signed the Medicare bill. And we've all had 3 tools in our toolbox when it's come to dealing with those 2 graphs, increasing costs and outcomes all across the page. And we've done 3 things, and we're actually pretty good at it. When we can no longer afford it, we cut people from care. States have done that. Our state expanded Medicaid in the 1990s, and then we cut everybody in the year 2000, and now we've added them back in 2010. But businesses do that as well. When I came to the state of Oregon in 1991, pretty much every business that offered health insurance offered full family coverage. Now today they still offer full family coverage, but now the employee needs to pay full premium for the dependents and for the spouse. And what that's done has meant that most of those dependents and spouse for hourly workers no longer can afford it, and they've been, in essence, priced out of care. The other thing we do is we cut services. We create new benefit packages, we cut teeth, we cut feet, we cut mental health services, we create new and different benefit packages. That's our second trick. And our third is we cut provider rates, or we shift costs onto consumers. And we're all very good at that. We as states are excellent at cutting provider rates, or just not having them rise with inflation. We've seen the Medicare doc fix how many times in federal health policy over the last couple of decades. We continue to use this as a tool. And I stand here today and say, how effective has this been for us? Is healthcare any more affordable? Have we been able to deal with the disparities, the outcomes? Have we created a better healthcare system by using these 3 tools? And the answer is no, that there's got to be a better way. So in Oregon, we set out to create what we really thought was a 4th path. How do we not focus on cutting people, cutting rates, and cutting benefits, but how do you fundamentally change how healthcare is delivered to change how care is delivered so that you can reduce waste, improve health, create local accountability, create the most important thing, which is fiscal sustainability. Otherwise, we're all going to go down into the sinkhole. So everyone always says, well, what does that mean to change how care is delivered? So let me tell you a story. It's a true story. This is Malik. And Malik became our poster child for what it means to change how care is delivered. Malik is 10 years old in this picture, and he's got asthma. And Malik had a great primary care doc. He had the best specialists, pediatric pulmonologists at our academic health center. And Malik had bad asthma. And he would end up in the emergency department about once every 4 to 6 weeks with an exacerbation of his asthma. He would get a URI, something would happen. He would go to the emergency department. He would have an exacerbation. He would get treated. He would get sent home. He would do well. And time again, Malik was in the emergency department. Malik got enrolled in a new way to deliver care to kids with asthma. And that was to send out a community health worker to his house, specially trained in looking for asthmatic things in the house that could precipitate asthma, helped actually remove some of the things in the house that were precipitating his asthma, bought the family one of these HEPA vacs that helps remove dust from the room, spent time teaching the family how to better take care of asthma. And over the next year, Malik never went to the emergency department once. That's fundamentally changing how care is delivered. Now, someone would say, well, why don't we do that for every kid? Well, the issue is, what's the billing code for a HEPA vac? There actually is none. And can you use Medicaid dollars to pay for a community health worker? Or for that matter, in many states, for most commercial insurance, and certainly for Medicare, you can't pay for unlicensed, lay-trained community outreach workers. Yet, an incredibly effective way to deliver care. And the truth of the matter is, I mean, when I took care of kids with asthma, the sicker they were, the more I got paid. And if I wanted to send out a community health worker, no one would pay me to do that. I had no budget. I got paid a 99213, 99214, 99215. The sicker Malik was, the more I got paid. But there was no money to fundamentally do what was needed to take care of Malik. So that is what fundamentally it means to change care. It means we've got to walk away from putting all of our resources where we put them all now. I think all of us know that a lot of what makes us healthy isn't just simply the medical care we get. That's about 10% of it. But a bunch of it is lifestyle, it's behavior, it's what we eat, it's what we drink, it's what we don't eat, it's what we don't drink, it's what we smoke, it's what we don't smoke. If you're a kid with asthma and you live next to a smelting plant, you're likely to be a lot sicker than if you don't. That it's our lifestyle. It's quite frankly, I think as everybody knows, it's where we live, and it's our socioeconomic status. And that in many ways our zip code has become equally, if not more important than our genetic code. This is Minnesota, and this is life expectancy by zip code. And you can go 10 miles, and your life expectancy can go from early 70s to mid 80s. So this isn't about focusing more and more of our resources on the medical interventions. It's how do we start to think about and consider care differently. And so that's what we sought to go and do in Oregon, is how do we think about how we fundamentally change how care is delivered. And you know, it's hard. So we spent about a year. We brought together about 50 people from around our state, some of the smartest people, leaders in healthcare, hospital systems, insurers, doctors, health policy experts, consumers, advocates, politicians, a group of about 50. And we met one night a week from 5 to 9 o'clock over the course of about 5 months to start to really think about and to map out what it would look like if we wanted to really meet the triple aim: lower costs, improve quality, and create a better healthcare system. And there were fascinating discussions. We came up with some blueprints. We then took it around the state, and we talked to communities, had meetings, probably well over 100 meetings over the course of 6 months with, in every community across our state, and built support for what we had come up with. Got the support of policymakers, got the support of the public, and what we got support for was what we called our coordinated care model. And the coordinated care model's got 6 ingredients that are pretty generic. And what those are is, we'll start over here. The first thing is a budget. Just like anything else, you've got to have a budget that grows at a sustainable rate. So our budget, which we set for coordinated care, was a budget for healthcare that grew at 3.4% a year, consistent with every other economic indicator in our state. The second thing you need is outcomes. You need to measure performance, and you need to be accountable to that. So we created a set of outcomes that were going to be what we were going to judge our health system by. The next thing you have to have is shared responsibility and accountability. Who's accountable for the dollars and who's accountable for the outcomes? Right now, we have a system where everybody points fingers. We think shared responsibility, as you see, lies within the major components of the healthcare system, those people who have skin in the game, meaning money, and consumers. So you have to have shared responsibility and accountability for the dollars and the outcomes. You need to have transparency. You need to be able to show what things cost and what the quality of the care is, what you're getting. You need to use the best practices, the best information, and then the last thing is, you've got to pay differently. You have to start to pay for the things you want, which is better health, not simply for more visits. So it isn't about paying for Malik to come and see me more. It's about paying for Malik to be healthy, and think about what it would be like if we had a healthcare system where no child with asthma ever ended up in the emergency department. If that was our goal, we would start to distribute our resources a little bit differently, and if we paid for that in a different way. We've all become very good at documenting so we can get paid for volume. It took us the last 20 and 30 years as doctors and nurses and others to perfect that. Now we're hopefully entering an era where we pay a little differently. So to take these 6 principles, we created coordinated care organizations. And the key to these organizations is, one, they're local, because all healthcare is local. Tip O'Neill said all politics is local, all healthcare is local. You can draw a circle with a 10-mile radius around any community, and all of the hospitals, doctors, nurses, pharmacists, you name it, that's your local healthcare system. But they don't work together. We often work at odds with each other. So how do you create a governance that brings people together? So the governance we created for these coordinated care organizations brought together a partnership between the 3 entities I talked about. The major components of the healthcare system, those taking financial risk, and consumers. That's the governing body of these CCOs that's accountable for the outcomes and for the dollars. They had a strong consumer bent with a consumer advisory requirement and a strong relationship with public health. We took all of our funding streams in Medicaid and blended them together, taking mental health, dental health, oral health, physical health, put them into one budget because I got taught in medical school that actually the mind, the mouth, and the body were all connected, and they were integral to health together. We created an ability to use Medicaid funds flexibly. CMS doesn't let states pay for that community health worker up until recently, or to buy that vacuum, or to pay for a cord of wood or an air conditioner, or to pay for housing for someone with a substance abuse problem who's living on the street. So we got an ability to use Medicaid funds flexibly. These organizations have a global budget that grows at 3.4%. And they have to be responsible not just for the dollars, but for the outcomes, 33 outcomes that they get measured on. And the vision was that we would start by putting together clinical services, oral health, mental health, many of the components of the community, and then eventually branch that out with the understanding that it's putting all of those pieces together, which is what makes and can help communities be healthy. The vision was to use the state as an active purchaser. We purchase 30% of the health care in our state. How do we start with Medicaid, which is about 25% of the state, and spread that model to employee health for state workers and their families, for teachers, and then spread that onto the qualified health plans in our insurance exchange. And at some point, our belief is you reach a tipping point where this becomes the model of care in your community, and indeed, everybody hopefully aligns around a similar way of delivering care in the community. We created these coordinated care organizations, and they've now been up and running for the last 3 years. They care for over a million people in our state. 95% of our Medicaid population is cared for in these coordinated care organizations. We have 16. They're all locally based. And we now have begun this model for our public employees. And we have 2 CCOs that are providing care for people who work for the state. And we have the other commercial insurers that offer health care to state employees working on a similar CCO model where their growth in expenditure is capped at 3.4%. And they don't have the same governance, but they have to perform on the same metrics as the CCOs. To do this, we got a federal waiver. To be able to change Medicaid, you need to have a federal waiver, and it was pretty simple. We asked the feds to allow us to deliver care in these CCOs for Medicaid. We wanted flexibility in using funds so that we could spend healthcare dollars. We'd no longer be, slaves to codes for how we spent dollars, but we could use them flexibly to invest in communities and stop problems up front. We got an investment to do this. We got $1.9 billion, but there were some strings attached to that. We agreed to lower the state's Medicaid expenditures by 2 percentage points. And what that did is, although we got $1.9 billion, that guaranteed 4.9, almost $5 billion of a return on that investment to the feds in 5 years. And if we didn't meet our cost targets, we had to pay the money back. So we were all in. We said we would lower costs 2 percentage points, and if we didn't do it, we'd pay you back. And the other piece we had was we had to meet certain quality metrics. We had to deliver on our ability to not just lower costs, but improve care without doing the things we've talked about, without cutting benefits or cutting people from care. We had to maintain the same benefit level. In fact, people now get a better benefit level. and maintain our state's eligibility. And this is our state projected healthcare budget from 2013 out through 2023. The bottom solid line is without these reforms. The top line is by our ability to reduce costs by 2 percentage points in Medicaid and and state purchasing. And this is billions of dollars. This is billions of dollars every 2 years. That's tens of thousands of millions, which is really billions of dollars that we have now in our state to spend towards other services. And it's the gift, as you can see, that keeps on growing. Healthcare expenditures continue to grow, as they should. But we now can do that in a way that's sustainable and responsible. But it's not just about the money, it's about accountability to outcomes. So we've seen really big changes. Let me tell you what we've seen just in the last couple of years. We've gone from fragmented care to much more coordinated care. We've gone clearly from very disconnected streams to connected funding streams into one budget that now is sustainable. We as a state can pay for. We had no incentives for improving health before. Now we've got strong incentives. Every year, another percentage point of that global budget gets paid based on outcome, not just as a budget. We used to have limits on services. Now we have actually very flexible services. I was just out in a community where there was a gentleman who had been in and out of the hospital multiple times with pneumonia over the previous 2 winters. And it was pretty clear part of the problem was he had no resources to heat what he was living out off the grid. He had no resources to heat his little house. His coordinated care organization bought him a cord of wood. And that $165 investment, much like Malik, actually kept him out of the hospital that next winter. Now, is that cause and effect? I don't know. I don't think anybody will know. But the issue is people were able to start to use dollars flexibly to impact people's health. In fact, I was out in a community probably about as rural and about as conservative as you can get in this country, and sat down with a bunch of physicians last week. This is in rural Eastern Oregon. And I don't think you could find anybody more fundamentally against national health reform, more politically on the right than is actually imaginable in our incredibly divisive political environment these days. And these guys sat around and said, they talked about social determinants of health. I didn't have enough fingers to count the number of times these 5 docs, the last people in the world you would think about, talking about social determinants of health. That's who I think the latte drinking people in Portland are going to talk about. And it was pretty dramatic. And who talked about how now they had accountability and local control of their healthcare dollars. They loved it. There's now a community voice and local accountability. It wasn't some insurance exec in Portland telling them how to use their healthcare dollars out in Burns, Oregon, where there's one of the last publicly funded boarding schools, because kids live a 2.5-hour drive from the nearest elementary school, so they actually board there during the week. Think about that. Are we meeting the triple aim? Yeah, we are. All of our CCOs are living within the budget, and then more importantly, we're improving care. So this is emergency department utilization from the year before our CCOs started to the 2 years after. Emergency department visits are down 20%, and emergency department costs are down 20%. And this is in a state that we had managed Medicaid. So these are all people coming from an incredibly managed environment where these CEOs used to tell me, we've gone as far as we can, Bruce. We can't make care any better. With this new model, they were able to decrease emergency department utilization, but it's not about cutting everything. Huge investments in primary care. Primary care visits, primary care expenditures up about 20%. Huge investments in creating patient-centered primary care homes. Adult hospital admissions for ambulatory sensitive conditions, the kinds of things you want to have happen, things that if you do a good job as an outpatient, you can keep people healthier. Adult asthma down 39%, chronic lung disease down 40, these are admissions, down 48%. Heart failure down 34%. These are the kinds of things that have happened. We publish these results quarterly. It's all transparent. This is a busy slide, but this gives you all of the 16 CCOs on one side of the ledger, and the dots are, the silver dot is the baseline, where they started, what their population was. The light yellow dot is where they were in 2013, and the dark yellow dot is 2014, and the line down the middle is the benchmark we're looking for in the state. And you can see pretty much everybody is progressing from silver to light orange to dark orange. Some aren't. There's some variation in performance. This is just one indicator, emergency department utilization, but we've got about 33. We also publish the results based on race and ethnicity. So we can begin to really focus on how we're doing as a state in meeting our health disparities. This is the congestive heart failure admission rate broken out by 6 different racial and ethnic groups to look at how we're doing and measure that performance. We've seen our communities go from being competitors to actually being collaborators. It's been pretty dramatic. You know, we had a lot of Medicaid managed care in our state. And we had some Medicaid managed care which was run by hospital systems, which tended to, our doctors would use a different term, but tended to disincentivize doctors. And we had a lot of doctor-run managed care organizations that tended to, what hospitals would say would be disincentivize hospitals. We've seen everybody playing one against the other in our communities. And now we've seen communities collaborate because they all had a stake in governance, particularly the behavioral health and the mental health community. We made a lot of investments in making this work, created a transformation center, learning collaboratives, peer-to-peer support, huge investment in non-traditional healthcare workers. You can't go anywhere in our state and throw a stone and not have a hit bounce off and hit 2 other community health workers somewhere. They're in the emergency departments of our hospitals. Our hospitals have hired them. Our large physician groups have hired them. Our insurance companies have hired them. Because it's clearly been shown to be incredibly effective in helping people improve their care. We've seen costs get lowered and outcomes increase because of a couple things. One, people have innovated. It's kind of like that scene from Apollo 13 where they get all the pieces and sit around the table and scratch their head and try and figure out how to make the air purifier. Well, that's what our communities have done. We've given them the dollars, and they sit around and figure out how to make that better, and they innovate. And they've got the ability to, at a local level, innovate on how to do this. And they've done all the kinds of things you'd expect. They've focused on the 20% of the population that use 80% of the resources. They've put large investments in primary care. They've integrated funding streams. They've paid for electronic health records in their communities so people could communicate. We've had incredible investments in telehealth because we have a hugely rural state and where people live hundreds of miles from care, and how do we invest in that? Our next steps, we've been now moving this model to public employees into our insurance exchange and hoping to leverage some of this into our commercial model. We've had a lot of challenges. This isn't easy, and we're far from done. And I could talk about challenges for a long time. Time, resources, and expectations are a huge challenge. Change is hard. Change is really, really hard. Change is really, 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 really hard. And it's been very hard to get a lot of us that have been trained in a certain way to change. Integrating mental health and physical health sounds really easy. It's really hard. There's huge cultural and structural differences that make this hard. Integrating oral health is probably equally as challenging. Making certain you have robust provider networks. Just saying we're going to pay for care differently, it's easy to say. It's really hard to do. What does that really mean? How do you set up systems that are equitable and that incent people for the right things? It's really, really hard. How do you account for these flexible services? How do you account for the Court of Wood or for the community health worker? These are really important questions. We've had to grapple with antitrust issues. What's it like when you get all the doctors and hospitals in a community sitting around the table to govern this organization? Are there antitrust issues? We've had to deal with the issue of actuarial soundness, which, as you know, tends to embed last year's inefficiencies into our healthcare system and has us move those forward. We're facing penalties for not doing our job. We've got issues about how you train and use new healthcare workers. A huge issue we haven't solved, I don't think anyone has, is how do you create some personal responsibility for health? I mean, that's the biggest vexing question for all of us in healthcare. But how do you do that? How do we exchange information? I mean, there's tons and tons of challenges out there, but we're making some headway. We've learned a lot. We've got a lot more to learn. I mean, the biggest thing we've learned are you've got to have a common vision. And by a common vision, that common vision needs to be shared by, in health policy, sort of a couple, 3, 4 arenas. You've got to have a common vision that's shared by your policymakers. Unlike what we see nationally, where we don't have a common vision, but to have a common vision of what healthcare should look like, a common vision amongst those people who provide healthcare services, who work day to day within it, of those people who pay for it, and of consumers, those of us who get care. How do you create that common vision? That takes work. You've got to engage all of these people in creating that common vision. Just ramming down changes politically is a disaster. We were able to pass this. I told you we had 30-30 in our House of Representatives. We passed our health reform 57-3 and 29-1 in our Senate. Huge bipartisan support because people bought into this. One side of the aisle bought into local control and fiscal accountability. The other side of the aisle brought into the fact that no longer were we going to cut people in benefits and we were going to make government work. It was really very, very interesting. Changing payment is critical. How can you expect to do things differently but yet pay for it the same? It just won't work. You got to have reliable data and information that everybody trusts. You've got to communicate early and often. And quite frankly, you can't communicate enough. Just when you think you've communicated about this, you need to communicate again because we all think about this totally differently. So let me spend a minute talking about what Lloyd wanted me to talk about, which is challenges and opportunities at the state level. So I think right now we're in this third wave of opportunities for state reform. I think we've seen the fact that national reform doesn't work in this country because we have 50 different healthcare systems. And that the real change actually does happen at the state level. So the opportunity for state health reform is actually national health reform. One, it's made us all realize that we're not going to solve this nationally. Number two, it's made us all realize that regardless, all healthcare is local. And that's how we're going to make the change. Number two, our biggest opportunity is the fact that no one can afford it. And that creates a focus on, it creates our burning platform. And you gotta have a burning platform to be able to change. It's an ever-increasing budget item for states and for businesses. And that creates a great opportunity. The other great opportunity is there's some really fascinating things going on around the country. And it's really easy to steal them. And there's a lot of models around the country, and we've stolen brazenly from a lot of things that a lot of states have done. All healthcare is local. And that's a real opportunity. People really value their healthcare. They see their healthcare as uniquely local, and they want to help make that change. And so all of those are real great opportunities. And then, of course, with every opportunity, we have some challenges. And the challenge right now, and what I see as probably the biggest challenge, is the political discourse in our nation. That we've gotten to the point where not only has the political discourse gotten so divisive, but the political discourse around healthcare is particularly divisive. And you saw the map. I mean, that's really divisive, and when you even sit down and talk to some of these governors who want to expand but can't because of politics, that's tough. The arc of change in healthcare, and particularly in public policy, is really long. You know, Daniel Patrick Moynihan said, if you don't have 30 years to devote to public policy, don't get involved. And I think that's really hard for particularly people who work in healthcare, and particularly doctors and nurses, who like writing, doing an intervention and watching things change. The arc of change in public policy is really long, and that's a lesson that was tough for me to learn. We're all impatient. It's really complicated. Healthcare is really complicated. I've spent my career in health policy, and I don't understand it. And it's really personal. It's really personal to people, and that creates a really tough dynamic. Yogi Berra said, if the other teams win, it could cause problems for us. And that's how I view Medicare, as a challenge on the state level. Half of what we spend at the state level is Medicare money. So if you've got the feds doing one thing and you as a state want to do something different, it's really, really challenging. We've tried to petition the feds multiple times. You can see how successful we've been to actually get all Medicare funding. We really think if we can get all Medicare funding and put it into our CCO model, we can create better care for Medicare beneficiaries and create an incredible return for the federal government, far dwarfing the $5 billion. But that's got a lot of other political challenge. There's, quite frankly, a lot of money in the status quo, and that's a hard challenge. And when you have healthcare, which has become close to 20% of our gross domestic product, be that much, that's a vested interest that's really, really hard to change. And that's a real challenge. And I think the last piece is leadership. We could use more leaders around healthcare in our country. We certainly know we need more in our state. Our state has a paucity of leaders, and we have a lot of people who have a lot of strong opinions. But having real leadership amongst the healthcare and the political community. We were able to tap into some of that to get this done, but we need more. So those are some of the challenges, and the bottom line is there is great opportunity out there, and I think we as states can create it. So let me stop there and open things up for questions.